Hi everybody, and welcome to our module on chronic heart failure. Shown on this slide is the way that I recommend you think about the treatment for heart failure. So when patients with heart failure have acute heart failure, they are acutely ill. They're usually very short of breath, they have lower extremity pitting edema, they have pulmonary edema, and many times these patients are treated in the hospital. And in another video I talk about how we treat acute heart failure with drugs like loop diuretics and nitroglycerin and inotropes. Now, once we've removed a lot of the fluid from patients and they are decongested, they often feel better, but they're still sick. They now have what we describe as chronic heart failure, and there are lots of studies showing that even when patients with heart failure feel better, they're still at great risk for dying from heart failure or having their disease progress. So what we're going to talk about in this video are a number of drugs and other therapies used to treat chronic heart failure. And when we're treating chronic heart failure, this is where the distinction between diastolic heart failure and systolic heart failure is very important because the two conditions have very different treatments in the chronic phase of the illness. So in chronic heart failure, there are lots of therapies that have been shown to be effective for treating systolic heart failure. These include a number of different types of drugs. We'll talk about all of these in this video. This also includes devices like implantable defibrillators and biventricular pacemakers. And all of these interventions in chronic systolic heart failure lower the risk of dying from heart failure, and they also lower the risk of the heart failure getting worse over time. Unfortunately, there are no direct therapies that work on diastolic heart failure. Many drugs and devices have been studied, but the clinical trials have all been negative. So if you read the American Heart Association guideline recommendations for diastolic heart failure, what they say to do is treat hypertension, diabetes, and AFib, all the things that might make heart failure worse. But of course, you would do this normally. There really aren't any specific therapies directed at the heart. So the mainstay of treating chronic diastolic heart failure is simply to monitor for symptoms and treat the patient with diuretics early if they start to become congested. That's very different from systolic heart failure, where there are lots of different interventions that can help the patient. An easy way to keep straight in your mind all the different drugs that are used in chronic systolic heart failure is to appreciate that in chronic systolic heart failure there is overactivation of two physiologic systems. The first one is the renin-angiotensin-aldosterone system, and the second one is the sympathetic nervous system, especially beta-1 receptors in the heart. So if you block the activation of these two systems, that leads to improved outcomes in systolic heart failure. And in fact, many clinical trials of drugs used in chronic systolic heart failure have shown a decrease in mortality and disease progression in patients who take drugs that block these two systems. So we'll start by talking about drugs that block the renin-angiotensin-aldosterone system, and by way of review, this is a slide from some of our renal videos showing you how this system works. So angiotensinogen is produced in the liver, and then renin converts angiotensinogen into angiotensin 1. Angiotensin converting enzyme, or ACE, is found in the lungs, where angiotensin 1 is converted to angiotensin 2. And angiotensin 2 has all of the effects shown on this slide here. It can activate the sympathetic nervous system, it can promote sodium and chloride resorption in the kidneys. Angiotensin 2 is a powerful arteriolar vasoconstrictor. It also can stimulate the adrenal gland to release aldosterone, and finally it can activate the pituitary gland to release ADH. And the net result of all of these effects of angiotensin 2 is more salt and water retention, higher preload, higher peripheral resistance, and higher afterload. And all of these things are bad in chronic systolic heart failure because the heart is weak, so it doesn't want that extra work. So there are two classes of drugs we use in chronic systolic heart failure that blunt this system. The first class are the ACE inhibitors, and the second class are the angiotensin receptor blockers. And both of these drugs can also be used in hypertension and other scenarios, but in chronic systolic heart failure, we're going to use them to blunt the activity of this system and improve outcomes over the long term for patients with reduced ejection fraction. So let's talk in more detail about the two classes of drugs that are used to blunt the renin-angiotensin-aldosterone system. Those are the ACE inhibitors and the angiotensin receptor blockers. ACE inhibitors are drugs that end in pril, like captopril, enalapril, or lisinopril and ramipril. They all block the conversion of angiotensin 1 to angiotensin 2. The ARBs are drugs that end in sartan, like candesartan, irbesartan, and valsartan, and these drugs all directly block the angiotensin 2 receptor. And the reason we use both of these classes of drugs in chronic systolic heart failure is because they have been shown in numerous clinical trials to reduce the mortality from systolic heart failure and to reduce the number of hospitalizations for patients with chronic systolic heart failure. The side effects of both classes of drugs include hyperkalemia. That's because these drugs decrease the release of aldosterone from the adrenal gland. In addition, they can both potentially cause renal failure. That's because they can decrease the glomerular filtration rate. ACE inhibitors have a couple of unique side effects you need to be aware of. Both of these are related to increased levels of bradykinin, which we'll talk about in a minute. These two side effects include dry cough and angioedema. About 10% of patients who take an ACE inhibitor will develop a dry cough and be unable to tolerate this class of medications. Angioedema is rare, but it's a potentially life-threatening side effect of ACE inhibitor drugs. Angioedema involves swelling of the face and tongue. This is a picture of a child who has angioedema from a bee sting, but this can also develop in patients who are taking ACE inhibitors, and this can potentially lead to swelling of the larynx, and then it can be a life-threatening condition. So ACE inhibitors blunt the conversion of angiotensin 1 to angiotensin 2. This is a good thing, and this is part of their clinical benefit. However, ACE inhibitors also blunt the breakdown of bradykinin into inactive metabolites. Bradykinin is a signaling molecule, and when levels of bradykinin get high, this can lead to the cough associated with ACE inhibitors. It can also lead to vasodilation, which can potentially lead to angioedema. Next, let's talk about beta blockers for chronic systolic heart failure. If you had attended medical school in the 1970s or 1980s, you would have been taught that beta blockers are contraindicated in chronic systolic heart failure. The reason for this is because these drugs are negative inotropes and they impair contractility. It turns out, however, that these drugs are very beneficial in chronic systolic heart failure. However, they are still not used in acute heart failure. When patients present to the emergency room with pulmonary edema and pitting edema and they are in acute heart failure, we don't administer beta blockers. That's because they can worsen cardiac output and symptoms. However, when that patient is decongested and feeling better and enters the chronic phase of systolic heart failure, that's where beta blockers are very beneficial. So there are three specific beta blockers that have been studied in chronic systolic heart failure and shown to be beneficial. The first one is metoprolol, which is a beta 1 blocker. The second one is carvedilol, which is a blocker of beta 1, beta 2 receptors and also alpha 1 receptors. And the third one is bisoprolol, which is a blocker of beta 1 receptors. All three of these beta blockers have been shown in clinical trials to reduce the mortality from chronic systolic heart failure and to reduce the number of hospitalizations from chronic systolic heart failure, and that's why we use these drugs. Next, we'll talk about drugs that are antagonists to aldosterone. So on our slide of the renin-angiotensin-aldosterone system, I talked about how angiotensin 2 can stimulate the adrenal gland to release aldosterone. And in the renal videos, I talk about how aldosterone promotes retention of sodium and chloride from the kidneys. So there are two drugs that block the effects of the hormone aldosterone, spironolactone and eplerenone, and both of these drugs can be used in chronic systolic heart failure. Spironolactone and eplerenone are aldosterone blockers, but they're also in a class of drugs called potassium-sparing diuretics, which I discuss in more detail in the renal section in the video on diuretics. But the reason they're in this class of drugs is because they both increase sodium and water excretion by the kidneys, and therefore they are diuretics. And they are said to spare potassium, which means that unlike other diuretics, especially loop diuretics, they do not increase potassium excretion. Therefore, they do not lead to hypokalemia. They can, however, lead to hyperkalemia because they block potassium excretion by the kidneys. And the reason they're used in chronic systolic heart failure is because just like beta blockers and other drugs used in chronic systolic heart failure, they have been shown in clinical trials to reduce mortality and reduce the hospitalization rate. I want to make special mention of spironolactone. It has a number of peculiar side effects that can be hard to remember, but I'll give you an easy way to keep them all straight. Spironolactone structure is shown at the bottom of the screen, and you can see that it has a similar structure to testosterone. And if you remember this, it's an easy way to remember that spironolactone blocks testosterone effects. So in men, this can lead to a relative increase in estrogen effects compared to testosterone, and that can cause gynecomastia. And gynecomastia is a side effect that occurs in about 10% of men who take spironolactone. The advantage of eplerenone is that it's a modified version of spironolactone and it does not cause gynecomastia. So it's marketed as an alternative to spironolactone for men who develop gynecomastia. Spironolactone is also derived from progesterone. This is progesterone structure on the bottom right side of the screen here. Spironolactone is a chemically modified version version of progesterone. And if you know that, then you can remember that in women, spironolactone can activate progesterone receptors, and this leads to amenorrhea. When progesterone receptors are activated, that mimics the conditions of pregnancy, and therefore a woman won't menstruate. So some women who take progesterone develop amenorrhea for this reason. Next class of drugs for chronic systolic heart failure are the neprilysin inhibitors. There's one drug in this class, it's called sacubitril. So neprilysin is an enzyme that degrades atrial and brain natriuretic peptides. So when you inhibit neprilysin, you get higher levels of ANP and BNP. Now you may know that ANP and BNP are elevated in heart failure, but they're not elevated enough to do their job. By inhibiting neprilysin, you raise their levels even higher, and this makes them more effective hormones. Basically, ANP and BNP are antagonists to the renin-angiotensin-aldosterone system. That's why I've shown this little seesaw at the bottom of the screen here with the RAS system on one side and ANP and BNP on the other side. So if you boost the levels of ANP and BNP in the body, this is able to knock down the effects of the renin-angiotensin-aldosterone system, and that's beneficial in systolic heart failure. So effects of ANP and BNP that counter the renin-angiotensin system include vasodilation. These hormones are natriuretics, meaning they promote sodium excretion. They're also diuretics, meaning they promote water excretion. They also reduce the sympathetic tone. And all of these effects blunt the deleterious effects of the renin system and the sympathetic nervous system in chronic systolic heart failure. Sacubitril is not marketed as an individual drug. It is marketed as Entresto, which is an oral combination of sacubitril and the angiotensin receptor blocker valsartan. The idea here is to use sacubitril to boost the ANP-BNP system and to use valsartan to knock down the renin-angiotensin-aldosterone system. And indeed, in clinical trials, this combination in Entresto has been shown to lower mortality rates and lower hospitalization rates for patients with chronic systolic heart failure. To understand the side effects of sacubitril, you need to appreciate that this drug has only been studied in combination with the angiotensin receptor blocker valsartan. Therefore, in clinical trials, many of the side effects seen were similar to those seen with angiotensin receptor blockers. These are things like hypotension and hyperkalemia. The feared side effect of neprilysin inhibition is angioedema. Luckily, this is rare. The reason for this is because neprilysin also degrades bradykinin, just like angiotensin converting enzyme does. Therefore, when you inhibit neprilysin, you get a similar effect to what is seen when you inhibit ACE. The levels of bradykinin can rise and angioedema may occur. And for this reason, neprilysin inhibitors like sacubitril cannot be given together with ACE inhibitors because the risk of angioedema becomes too high. The last drug I'll discuss in this video is ivabradine. This drug was very recently brought to market. It is a selective sinus node inhibitor. The idea behind this drug is that clinical studies have shown that heart failure patients with higher heart rates have a worse prognosis. This is probably because their heart is working harder to maintain their cardiac output. So the idea behind ivabradine was that if you could slow the heart rate without decreasing contractility, there might be a benefit for systolic heart failure patients. So the way that ivabradine works is that it inhibits the sinus node pacemaker called the funny current. In the video on cardiac action potentials, I talk about the funny current, which is responsible for phase 4 of the pacemaker action potential. This current is responsible for setting the rate of depolarization of the SA node and therefore the heart rate. So when you inhibit the funny current, you slow depolarization of the sinus node and therefore you slow the heart rate, and you do this without affecting contractility because you are not affecting beta receptors in other parts of the heart. This is used in patients who are on max dose beta blocker who still have a high heart rate, and there is some limited evidence that chronic systolic heart failure patients who take this drug have decreased mortality and decreased hospitalizations. So as I said at the beginning of this video, for chronic diastolic heart failure, there really are no therapies that directly target the heart. However, for chronic systolic heart failure, there is a long list of drugs that improve mortality and reduce the rate of hospitalizations, and that includes all the drug classes on this slide that we've gone through in this video. I'll finish this video by talking about two devices that can be implanted in the chest of patients with chronic systolic heart failure to improve outcomes. The first type of device is called an ICD, which is short for an implantable cardiac defibrillator. It turns out that in patients who have a low ejection fraction, the annual risk of sudden cardiac death is as high or greater than 20% for some patients in some studies. Most of the cases of sudden cardiac death are caused by ventricular tachycardia, which is the heart rhythm shown on the screen here. This is a dangerous cardiac arrhythmia. It can lead to ventricular fibrillation and cardiac arrest, and this is a mode of death for many patients with systolic heart failure, and this can potentially be prevented by implantable cardiac defibrillators. So an ICD is a small device. It fits in the palm of your hand. It's got a battery that lasts about 5 years, and it has a wire that connects to the heart, and it constantly monitors the heart rhythm. And if it detects a dangerous heart rhythm like ventricular tachycardia, it will deliver electrical therapy. Basically, it will try to pace the heart or shock the heart back into sinus rhythm. And this improves mortality and prevents sudden cardiac death in appropriate patients. Now, it's not for everyone. Implantation carries some risk. There's risk of bleeding and infection. There's also risk of inappropriate shock. Sometimes the defibrillator gets confused and it shocks the patient for sinus tachycardia or atrial fibrillation. So in my field of cardiology, we spend a lot of time determining who is appropriate for an ICD. But all you need to know for step 1 of the USMLE exam is that in selected patients with chronic systolic heart failure, this device can improve mortality. Another device that can be implanted in patients with chronic systolic heart failure is called a biventricular pacemaker. This is also called cardiac resynchronization therapy, or CRT. It's also sometimes called a BiV pacemaker for short. So if you look at the heart on the left side of the screen here, this is a heart from a patient of mine who has a very wide left bundle branch block. And hopefully you can appreciate that the heart is contracting out of sync. When one wall comes in, the other one goes out, and vice versa. In fact, it looks like the heart is swinging in the chest. On the right side of the screen is the same patient after implantation of a biventricular pacemaker. This pacemaker has a battery that's implanted much like an ICD. It's got wires that attach to both walls of the left ventricle, and the pacemaker forces the walls to contract at the same time. This generates a synchronous contraction, as is shown on the right side of the screen, and this improves the cardiac output. And for appropriate patients, this improves mortality and reduces heart failure from chronic systolic heart failure. And just to clear up a point of confusion, this is a very different type of pacemaker from the type used for patients with slow heartbeats. In the video on AV block, I talk about using pacemakers for patients who have bradycardia. That's an entirely different kind of pacemaker. In this case, we're using a pacemaker to make the left ventricle contract in a synchronous manner to improve the outcomes for patients with systolic heart failure. So I'll finish by going back to this slide, which summarizes the way I recommend you think about the treatment of heart failure in your mind. For patients who have acute heart failure and are congested, we use all the therapies I talk about in the video on acute heart failure treatment. This includes Lasix and nitroglycerin and inotropes. Once patients are decongested and feeling better, they now have chronic heart failure, and they need specific therapies depending on whether or not they have diastolic or systolic heart failure. For diastolic heart failure, there's no specific therapy. Mostly we just monitor these patients for symptoms. In systolic heart failure, there are many therapies that have been shown to be beneficial. This includes all the drugs we talked about in this video, plus devices like ICDs and BiV pacers. And that concludes our video on chronic heart failure treatment.